My name is Siobhan Statuta, and I'd like to extend a very warm welcome to the National Fellow Online Lecture Series. Tonight, we're going to be hearing, let me advance this, about the pharmacology of mental health in the athlete. And this is a topic very near and dear to my heart, but also I think is more and more essential for those of us who are practicing and especially those of all of us who are still training and trying to stay up to date on sports medicine. So tonight promises to be a really great talk. Just a couple of things that we should go through. The goals of the lecture series is to serve as an adjunct to your individual program's educational programming. It's to provide fellows with direct access to educational experiences with experienced AMSSM members and at times invited guest lectures in a variety of formats, and to also help with CAQ exam prep and recertification for those of us who may be at that point in our careers. So please mute your device's microphone and turn off your video. Submit questions through the chat function, include your name and program if you wish. And I, the moderator, will ask these questions during the question and answer at the end based upon any questions you submit. After the program, please complete any evaluation which will be sent at the end of the lecture. So before we delve into tonight's talk, there's going to be a little bit of a teaser. Not next week, but 2 weeks from now, you can hear Dr. Jim Mueller, who is the godfather, grandfather of this Fellowship Online Education Lecture Series. And he's going to be speaking on non-operative management of osteoarthritis with a wonderful moderator, Dr. Rubish. So that's coming up in it says September 7th. That's not correct, you guys. It's in 2 weeks and the last day of November. So I apologize for that. But back to today's event, the pharmacology of mental health in the athlete. And I'm really honored to be able to introduce you to my colleague and my friend, Dr. Carrie Jaworski. I would like to tell you just a little bit about her. I know many of you guys are in your training, so just sit back and listen to these amazing things that Dr. Jaworski has accomplished in her short years practicing. Dr. Carrie Jaworski is a board-certified family and sports medicine physician who recently joined Intermountain Healthcare as the Associate Director of Sports Performance at Park City Hospital. Dr. Jaworski previously served as the founding director of the Division of Primary Care Sports Medicine and the Primary Care Sports Medicine Fellowship Director within the Department of Family Medicine at North Shore University Health System and the University of Chicago Pritzker School of Medicine. Her clinical and research interests include endurance medicine, mass participation events, concussions, the pediatric and female athlete populations, nutrition, supplements, dance medicine, and the promotion of exercises medicine. Now, with 25 years in practice, Dr. Jaworski has had countless experiences in the care of athletes at all levels. She currently is the medical director for the Utah Olympic Legacy Foundation and is sports medicine lead physician at Intermountain Health for the USOPC's RED-S referral network in the Western region. She's previously served as head team physician for Northwestern University Athletics, where she was their director of intercollegiate sports medicine. Dr. Jaworski has had the honor of being a physician at the Salt Lake Olympics in 2002 and again in Tokyo in 2021. She will lead Team USA again in Paris as a lead physician for the Paralympic Games. She has covered the Ironman World Championships in Kona and served as lead physician for the Bank of America Chicago Marathon for several decades. Dr. Jaworski is frequently an invited speaker on the national and international levels and has published numerous books and chapters and articles pertaining to sports medicine. She is active within within the American College of Sports Medicine and previously served as one of their vice presidents. Now, as if that's not enough, in her spare time, Dr. Jaworski enjoys all things outdoors, particularly running, marathons, hiking, biking, tennis, and now Nordic skiing. So without any further ado, you guys, I'm going to turn this over to Dr. Jaworski to teach us about the pharmacology of mental health in the athlete. Thanks for joining us, Carrie.
Oh my gosh. Thank you, Siobhan. I guess the one thing I don't know is how to operate Zoom though. So I apologize to all of you guys. My computer is being stubborn tonight. So we'll get through this. I will be looking at my screen at my slides and trying to talk to you through my phone. So apologize for this old girl can't get Zoom working over here. I'll blame the altitude. How about that? Um, so I have been tasked with this huge topic, which is both huge in its quantity or what we need to talk about, but also in its importance. Like Siobhan said, I think mental health is near and dear to my heart as well. And this was truly a learning experience for me as well. So thank you for forcing me to kind of brush up on my knowledge, because for most of us, we're not doing this day in and day out on all of our patients, but we definitely are managing mental health on a daily basis. So we can go ahead and go to the next slide, which just says I have no disclosures. And then really our learning objectives tonight, I want to review the most common things that we would see as sports medicine physicians in terms of managing mental health from a pharmacology standpoint, as well as understand how the medications that our athletes are on can impact both their performance and their eligibility, as well as just explore what our role really is in all of this alongside our psychology and psychiatric counterparts. Next slide, please. So we have a couple questions. I think I don't know if it's going to work for, it is going to work for Zoom. So go ahead, you guys, I want you just to answer these questions and then we'll come back to them at the end. So go ahead and enter your choice for which medication you would not consider in the first scenario, which if you can't see it again, it's Alice is a 20-year-old collegiate distance runner who's already under treatment for a restrictive type eating disorder, and she's now presenting with concerns about depression. And which of the following medications would you not consider a first line choice for her? So which one of those? Go ahead and submit your, I guess I need to submit my answer too, but I know the answer. Okay, so number 2. Oh, we're going to go ahead. Okay, we've got some smart cookies here. I won't spill the beans till the end, but we're on the right track. So question number 2 or scenario number 2. 24-year-old professional triathlete presents to you for evaluation of insomnia. What is the initial medication of choice for this athlete? And then we can go to scenario 3. Good job. I might not need to give this lecture. So, next question, please. Okay, so scenario number 3, which of the following is banned by the World Anti-Doping Agency? All right. All right, and we will come back to all these questions throughout the lecture, so we can go ahead and move on to the next slide. So really when we're talking about pharmacology or medications and mental health disorders in athletes, there's a couple of things to think about. So what do we know? I think we are very well aware that mental health is at the forefront of everyone's topic of conversation, both with and outside of athletics. And we've seen so many of our professional athletes coming forward, which I think has really created an opportunity for us to have that conversation with our athletes. The awareness that, people like Simone Biles and Michael Phelps and Naomi Osaka all coming forward at pivotal points in their careers and taking that step forward to say that they're having trouble, they're struggling, they need to step away, has really kind of made this a much more approachable topic for us with our athletes. And so I think that's incredibly important, and whether or not we choose to use medications in their treatment isn't the point, but the point being that we can now have those conversations in a much easier manner for a lot of people. That being said, each of us has varying degrees of comfort level in terms of the actual pharmacologic management of mental health disorders, and it may vary depending on whether we're treating depression versus anxiety or ADHD, and it comes from our original training, whether we were, emergency medicine or family medicine or pediatrics. So we each come from a different background. And so I think, just understanding where your comfort level is, and then getting the help that you need when you need it. And I think that's probably where a lot of limitation exists, is that in various communities, there aren't a lot of people in the sports psychiatry or sports psychology world. So our elite athletes often have the benefit of some excellent care. But when we're talking about our high school athletes or our weekend warriors who are struggling with similar conditions, we may not always have those resources in our own communities. So, really being able to tap into our colleagues within AMSSM and getting help, even if it is virtually, I think can be a step in the right direction. Next slide, please. In terms of the actual use of medications in athletics, it's really limited in terms of our knowledge base, in terms of proven evidence-based medicine. So a lot of what we'll talk about is just what's, experiential, what's, consensus driven, but there are very few studies that do exist looking at the impact of these medications on athletes. And those studies that do exist are quite small, and they have, a lot of flaws within them. They're either small sample size, a very short duration, a much higher dose of the medication than what we would normally use in our daily practice, or just lack of subject diversity. So there's a big missing component when we're always looking at one particular type of athlete and not looking at different types of sports, as well as diversity within the sample population. So those are all things that we need to improve upon, and hopefully that will happen in time. Next slide, please. So generally what we're considering when we're trying to decide on a medication for our athletes, several things. So first and foremost, obviously, we want it to have a therapeutic effect on the symptoms that they're experiencing, whether that's depression or anxiety or whatnot. But we also need to take into account the negative impact it may have on their performance. On the flip side, we also need to take into account the potential performing enhancing effects it might have on their performance. So that, whether that is falling into the realm of something that's ergogenic and actually illegal within a sport, or if it's just helping them with the symptoms that they have from their mental health disorder and just getting them back to what would be considered more a normal baseline. So looking at those things. And then, of course, with certain medication, there are safety risks associated with them, and we'll go through that. Next slide. So generally speaking, the things that we think about most when we're talking about these groups of medications are the negative impact that they can have on the athlete. So things such as their mental alertness, so causing fatigue or sedation, their speed within their speed in sport. Weight fluctuation is a huge concern, as is GI distress, which often happens early on with many of these medications, any kind of movement disorder such as tremor, and then sexual dysfunction. Next slide. In addition, performance enhancement needs to be taken into account. So both the ethical considerations. So, I think the best example of that is stimulant use with attention deficit disorder, and using that for performance enhancement and not necessarily for actual need. The doping considerations, and looking at both the rules within the World Anti-Doping Agencies, the NCAA, as well as all the other governing bodies of sport. And then next slide. So safety issues also are a concern. So, when we're talking about certain medications, you can reach toxic levels, and sometimes exercise can actually cause a rise in levels. Certainly heat issues with certain medications and how that impacts the athlete's health and safety, and then cardiac issues. Next slide. So just briefly, just thinking about the influences on a patient's or an athlete's mental health, there's many components to that, and you can see them listed. So, from the emotional standpoint, but mentally, physically, socially, spiritually, and then even the environmental impacts that all impact how an athlete feels, which then ultimately impacts how they perform both in life and in sport. Next slide. So there's some great resources, and they're listed at the end, but both AMSSM has their position stand, as well as the IOC, with many of our members being on that panel for the IOC statement, talks about really how do we approach mental health in athletes, and really it has to be athlete-centric. They have to be at the center, not only in terms of our focus on them, but them also having a central role in decision-making and shared decision-making on what we choose for treatment when we're talking about these conditions. And so it really needs to be integrated amongst the medical team, ideally evidence-based, and really address the full range of all those influences that are affecting the athlete's mental health. So next slide. So that's kind of setting the stage. As far as medications, where do medications fit in this? So truthfully, for the majority of the things we'll talk about tonight, counseling, psychotherapy should be considered as first-line treatment for majority of patients with mild to moderate symptoms. So it's often underutilized or underprescribed in athletes, and that can be lack of resources, that can be lack of buy-in from either the sports medicine team or the primary care provider taking care of the athlete, or the athlete themselves. But we know there's good evidence to support psychotherapy, particularly cognitive behavioral therapy, being most successful both in general population as well as in our athletic population. Athletes can be difficult though, so they have obstacles in terms of initiating care. So they might have limited time for counseling. They have personality challenges that make it difficult for them to buy into the process, or there may be diagnostic challenges where it's just being missed altogether and things are being, lumped into overtraining, and we're not addressing the mental health issues that are either coincident with it or actually the cause of their symptoms. So I think we need to take that into account. Certainly medications are typically initiated when we have our more severe cases, but we need to also be thinking about it in the more mild to moderate cases so that they don't become severe. But remembering that medication alone it's typically not the answer to the problems that we're dealing with when we're talking about mental health. And so we really need a comprehensive approach. And that being said, I still think there is a place for medication. Next slide, please. So we're going to spend the majority of our time talking about antidepressants. In particular, that's because it is the most prescribed medication class, both for mental health, and then it is the #1 prescribed medication in the United States for those between the ages of 20 and 59. So these medications are being used and used often. And so I think we owe it to ourselves and to our athletes to really understand all the different uses. So they can be used not just for depression, but for many other things. They're really still on the top of the list for anxiety. They can be used in things like eating disorders and concussions. They can be used with menstrual disorders and insomnia. So I think there's a place for them in a lot of different buckets. And so we really need to understand that. Again, understanding that despite the frequent use, it's still really limited in terms of the studies to support it in the athletic population. So we need to do our best to make sense of it for our athletes because we're the ones that are going to be managing it day to day. Next slide. Okay, so just a quick reminder, depression, if we're talking antidepressants, depression is the most frequent thing that we would be using it for. And this is just your diagnosis for major depressive disorder. And the reason I put that up there is because majority of the studies that do look at these medications are taking subjects who have major depressive disorder. That may not be the same as what we're seeing in our athletes. Many of our athletes might have adjustment disorders or dysthymic disorders, or not a major depressive disorder, but depressive symptoms. Even so, the medications still work similarly. We just need to understand the limitations again of the research. So next slide, please. Looking at the mechanism of action, when we're talking about medications, the main components that we're talking about are neurotransmitters, and serotonin, norepinephrine, and dopamine are the keys. And so most of our medications are going to work at those areas. And so remembering how that works, for instance, the SSRIs, which are probably the most common medications, they block the reuptake of the neurotransmitter. So you can see the synapse here at the nerve where the SSRIs are going to help to kind of keep more serotonin in that space, where we know with depression and with a lot of the mental health illnesses, the neurotransmitters are lacking. Different from SSRIs, your tricyclic antidepressants, rather than blocking the reuptake, they actually bind to the reuptake transporters and prevent reuptake of the neurotransmitter. So similarly, the purpose of all the medications are trying to keep more of the either serotonin, norepinephrine, dopamine, or some combination thereof kind of within the area to allow for a normal level and help with the mental health symptoms. So next slide, please. So in terms of antidepressant, really the first line are your serotonin reuptake inhibitors, or your SSRIs. And you can see the list here, just in terms of what are the common ones that we see typically used. In addition, your serotonin norepinephrine reuptake inhibitors are slightly newer, but also considered regularly used in our general population as well as in athletes. And then your norepinephrine dopamine reuptake inhibitors, which would be essentially the bupropion. And we're going to talk about all of these. But as you can see from the chart, depression is the main use for many of these medications, but then you also can see that it's used for some of our anxiety disorders, as well as bupropion for smoking cessation. Next slide. So talking about SSRIs, the function, like I mentioned in the previous slide, is really to increase the bioavailability of serotonin in our system, and the commonly prescribed medications are listed there and in the chart on the previous slide. Of all the medications that we're talking about tonight, SSRIs really have been shown with some limited research that they're not thought to negatively impact athletic performance. They're not on any banned substance list, so they're safe to use from that standpoint. The possible side effects with SSRIs you can see are listed. Gastrointestinal disturbances, mostly in the initial phase of starting the medication. Sleep disturbance and sexual dysfunction are some of the common ones. I think one of the big concerns for many are weight gain. And, in terms of looking at the research, the one that's least likely to cause weight gain is fluoxetine. The most likely to cause weight gain would be the paroxetine. But again, it's very individual, and there are sometimes reasons we choose one over the other, and a lot of it comes from experience or what you've had success with in other patients. So there's no one size fits all when it comes to choosing. But if we go to the next slide, it'll kind of give us a comparison of the medications. So looking at the different medications, you can see they all do have similar side effects in terms of the things that we've already listed, but their half-lives differ slightly. I think the thing that I have seen is Paxil seems to be less tolerated, at least in my experience. You tend to have more anticholinergic side effects than the others, tends to be a little bit more sedating. I tend to lean more on the sertraline kind of as the tried and true medication, while it has a little bit more risk for GI side effects early on. It tends to be well tolerated in the long run. And then your newer medications, so the citalopram and I'm just going to say Lexapro because I can't say the generic, but they tend to have fewer side effects and can be well tolerated, but there's some question with those that they may have more impact in terms of cardiac rhythm issues. And so you have to pay attention to that, be a little bit more careful with regards to those two medications. Next slide. So there's very few studies, so just bear with me here, but the studies that do exist, fluoxetine, there have been a couple studies that have shown that it really doesn't have an impact on performance. So you can see the small size of these studies, and they're older studies. One was in college athletes and the other was in cyclists, but basically the first study was only for 2 weeks, so not really even long enough to see a full effect, but they showed that there was no impact on strength or anaerobic capacity, power, or fatigue. And then the second study was on, again, just a small sampling of male cyclists, and they were taking a dose before the evening before in the morning of a time trial and did not impact performance. But again, it's hard to really draw any kind of conclusive decisions based on studies as small as this. Next slide, please. So similarly, paroxetine studies, there are 2 studies that are listed a lot in the literature that I reviewed, and neither of which is really impressive. One was of 7 cyclists, again, male, and the other of 8. One showed a little bit less of or one showed an effect and one showed that it didn't have an effect on performance. So again, it kind of doesn't really help us in the long run. Next slide, please. So our next group, the SNRIs, they tend to fall behind the SSRIs. So they're often used in those who might have concurrent anxiety. They do tend to be a little bit more energizing. So you do have to be careful if someone is having more of like a panic situation or really in terms of watching how energized they get. They function by increasing both the availability of serotonin and norepinephrine. And you can see the common ones that are listed there. Their side effect profiles are similar, but like I mentioned earlier, they can also have some cardiac effects, including elevated pulse and blood pressures. And so you just want to monitor if people are doing high intensity or endurance sports. And the question was if the norepinephrine reuptake is performance limiting. In some like anecdotal reports, it was saying that, or was thought to be, that the norepinephrine component might be performance limiting because there are other studies that have not supported that. So it's a question mark. And again, this has not really been studied in athletes. This is just being taken from the general population type studies. Next slide. So here you can just see, and this is more for your reference, to just see kind of the dosing of the SNRIs, the brand names versus generic, and then some of the things to consider in terms of how they interact with other medications and their side effects. So next slide, we're going to talk about bupropion. So this is another alternative in managing athletes with depression. These are to be used, or they're not to be used in people who already have anxiety or have an eating disorder, because with anxiety, it's too activating. And with eating disorders, it can increase your risk of seizure. So you want to avoid that in those two populations. That being said, it is the top choice when sports psychiatrists, there's an article that's referenced at the end. They interviewed sports psychiatrists, small study size, but looking at what they thought in terms of which medication they would use. And this was their top choice for isolated depression when it was not associated with anxiety. They function by inhibiting reuptake of dopamine and norepinephrine, as well as they're a nicotine receptor agonist. So you'll see it used for that, for nicotine addiction as well. It is non-sedating. Like I said, it has energizing properties, and that can be helpful in certain athletes. And it also does not appear to cause weight gain. So that can be appealing for the athlete as opposed to some of the other medications that we've already talked about. So really the ones I've mentioned thus far are the ones, when we look at what sports psychiatrists are doing, they're using the three categories that I've already talked about kind of as their front line and basing it on what other things they need to take into account with their athlete. If we look at studies on bupropion in the next slide, this is interesting. It's on the anti-doping agency's monitoring list. So it's not banned, but they're paying attention to it because there is some question about a potential performance benefit. And that goes back to because it has it helps with or blocking the reuptake of dopamine. Dopamine is thought to be the performance enhancing component to this medication. So the studies were interesting because they were done, or they were only seeing performance benefits when exercise was done in a warm climate and use of a high dose of the medication, single dose fashion rather than persistent use. So it was, again, very small study, but it did allow athletes to kind of push beyond at higher core temperatures and higher heart rates without feeling the effects of those high heart rates and high temperatures, which, while it's better for performance, can also be fairly risky from a safety standpoint, because if they're not recognizing those changes, it could put them at risk. So that was not seen with lower doses or with the recommended doses, only with the high dose, which typically wouldn't be used for management of mental health issues. Next slide. So tricyclic antidepressants have been around a long time, and they are used in certain situations, which we'll talk about. They're really not recommended as first line for anything that when we're talking about depression and anxiety. They have quite a bit of side effects, including cardiac arrhythmias. And there's also a question of with toxic blood levels when athletes are working out hard or sweating heavily. So we want to really be cautious in their use. They also can cause a significant amount of sedation and weight gain. This is less so in the secondary amines versus the tertiary. So nortriptyline tends to be better tolerated than amitriptyline. And if we look at the next slide, that just is going to give you that information that I just told you. So again, these are meant more for your reference when you go back to study for CAQs. Next slide. This is just kind of listing out the kind of by all the different medicines that we've mentioned, including some that I haven't mentioned, just what the adverse associations of taking antidepressant medications can be. So one thing we want to pay attention to is while GI effects can happen early on in the start of SSRIs. They also have an increased risk of GI bleeds when used concomitantly with NSAIDs, which athletes frequently do use. So we want to be cautious of that. And so I think that that's really important. The QT prolongation, like I mentioned with the SNRIs, is something that we need to pay attention to as well. Next slide. Oh, and pardon me. And we would be remiss if I don't mention suicide risk. So the age-related risk in our younger population. So those less than 18 in particular, we really want to be careful. And a lot of this has to do with just people who are in severe depression, and then they take medication, and now they've been activated and they have the energy. And if they have suicidal thoughts or plans, they may be more likely to act on those plans. So we want to have close monitoring when we're starting medications, particularly in our younger athletes. All right, next slide. So just to kind of summarize, the sports psychiatrists, in terms of their preference, really still cognitive behavioral therapy is first line with the medications you see listed as their choice, which I find interesting because paroxetine does have, in my mind, more side effects than some of the other SSRIs. So I would take this opinion with a grain of salt and still use what you're comfortable with or what you've had good experience with. Next slide is just an example of how to start medication for depression. And so remembering that most of these medications take several weeks to see the full response. So assessing them at 2 weeks and then again at 4 weeks. And if they're having a good response, maintaining that plan that you have in place. But if not, considering increasing or switching to a different medication. Really typically with treating depression proper, we want to give it at least a maintenance period of 6 to 9 months. Many people will need to stay on medication longer, but you can try, if they're doing really well, to come off of medication after that time. But it should be in the context of ongoing either cognitive behavioral therapy or some other supports therapy to kind of bridge that gap as they're coming off the medication. And sometimes you'll find that they do need to come back on the medication if their symptoms come back. Next slide. And then here's just a complete list of all the antidepressants you would ever want to know, but I won't read them to you tonight, but you can have that for reference. Next slide. The discontinuation of antidepressants is another thing to keep in mind. So the symptoms can flare. Their symptoms can flare if you stop the medication abruptly. So you want to be really mindful of that when you're taking a patient off medication. And this mnemonic is good to remember, that these are the symptoms that they may experience. And so there are good articles, both within the AFP journal, so American Academy of Family Practice, as well as the sports psychiatry websites, which can kind of walk you through how to taper various antidepressants. But essentially you want to go slow over the course of several weeks rather than stopping suddenly. And you can see from the table listed here, certain medications have much higher risk of symptoms on discontinuation. So you want to go even slower with those groups. So next slide. So in terms of anxiety, I think that still, interestingly enough, the medication of choice will be our antidepressants for the most part. But this is a reminder, generalized anxiety. Here's your DSM-5 criteria for how to diagnose generalized anxiety. Interestingly, it tends to be higher in female athletes, but that actually is similar for the general population, where females have more of a prevalence of generalized anxiety versus males. And typically we can see this also in athletes who've sustained injuries. There's limited data on the other types of anxiety disorders in athletes, but the data that is out there shows that social anxiety is probably the second highest thing that we'll see, along with obsessive compulsive disorder and then panic disorder. So next slide. So your anxiety disorders, they break them up again for treatment suggestions. This is just a nice algorithm to look at for the different types of anxiety. But essentially your SSRIs or SNRIs are usually first line for the majority of all of these things that we see listed here. So next slide. So in terms of other choices, so first off, your SSRIs, if we go back to that sports psychiatry survey, the three that they like the most for anxiety disorders tends to be your Lexapro, sertraline, and fluoxetine. Buspirone is not considered first line, and it's actually not recommended in athletes. It has quite a bit of side effects And so we try to avoid that. Sometimes it will be paired by our psychiatry colleagues with the SSRIs if people are struggling, at least at the initiation of treatment, but really not used as a first-line drug. And then benzodiazepines are not typically recommended, and we'll talk about that a little bit. Next slide. So in terms of performance anxiety, so oftentimes we'll have athletes of various sports who will say that they're having issues or will have issues with performance anxiety. And so beta blockers are frequently used in this realm. We need to be careful, though, that this in some sports can be actually performance enhancing, while in other sports it can actually be performance inhibiting. So we want to make sure that we're paying attention to that, and especially for the banned sports that I have listed here, the archery, billiards, golf, shooting, any kind of shooting sports, those would all be banned. And so we have to be careful when we're using those in those athletes. The next slide is clonidine. And this is used oftentimes, again, for anxiety, but also for PTSD. There aren't really any good studies that are in athletes. And interestingly, just to make note that this is not on the WADA ban list. So in terms of using it, it is safe to use. I think another big, next slide, another big component of what we see with our athletes is insomnia, and the NCAA as well as Olympic data supports that it's being seen in more than 50% of athletes to some capacity. And insomnia disorder is when the insomnia symptoms are persisting for greater than 3 months and impacting daily life. And so really, I think, again, our role is to be screening our athletes and be helping to promote healthy sleep habits, both through like educating coaches on practice times, whatnot. And non-pharmacologic treatments are really the preferred method of care due to many of the sleep medicines having significant performance impairments in our athletes. That being said, some of the common medications you can see listed: melatonin, benzodiazepines, non-benzodiazepines, and then also trazodone. So next slide. Of all the medications for sleep, melatonin is the one that we should turn to. So it's the most studied. It is preferred by our sports psychologists, both for insomnia and also for any circadian rhythm disturbance disorders. There's no negative impact on performance the day after use, which is where we'll typically see the impacts of the other medications. There is a small concern that it can affect or lower your blood pressure, but that has not been really supported in the literature. The one concern with melatonin is because it is an over-the-counter medication, it is not regulated. So we need to be really careful and be educating our athletes as we would for any supplement or over-the-counter medication, that if they're at risk for drug testing and this medication is somehow contaminated, they would be liable for that. So some people had suggested using Ramelteon, which is a prescription melatonin receptor agonist. There are no studies in athletes. Again, I know it's kind of keep repeating myself, but the one problem with this medication, while it would be safe because it's prescription, it does have a longer half-life, so it could theoretically impact next day performance if you're taking it for sleep disorders. Next slide. The other sleep aids, benzodiazepines, like I already mentioned, we really don't like to use them. There's lots of risk associated with benzodiazepines. So the longer acting benzodiazepines will have more carryover effect and symptoms the next day of sedation and delayed reaction times, versus if you stick with a shorter half-life, you may have less carryover effect, but you have a much higher risk of dependency and substance abuse in those medications. So again, not ideal for use in our athletic population. The non-benzodiazepine agonists, so things such as zolpidem and whatnot, they do have less carryover effect than the benzodiazepines, but there's still a fairly high abuse potential, and so we try to avoid those as well. Trazodone is used oftentimes for sleep. However, it has a carryover effect and can also cause hypotension, so we want to be careful. Again, it has not been studied for athletes in use of for insomnia. All right, next slide. We're almost done. So medications for attention deficit hyperactivity disorder. So we know that ADHD is thought to be more common in our athletes, and this can be for a variety of reasons. Actually, athletics is a good treatment for ADHD, as is exercise. So I think sometimes athletes or our patients will naturally veer towards sport as a way to manage their attention deficit. In general, stimulant medications are considered first-line treatment. They have the fastest onset, the most science behind them. And so they're often leaned upon as the only treatment, but we need to keep in mind, as opposed to everything else that I've talked about, we really want to still include the psychosocial interventions and use them in the treatment of these athletes as well. So there's so many things that can be done for, whether it's counseling on organization and study skills, but I think those things need to be coupled with the medication. Stimulants have a high risk of abuse and their safety concerns, and they definitely have ergogenic effect on performance. And you can see some of the things that are listed. So they have an effect on strength and acceleration, also anaerobic capacity, time to exhaustion, and maximum heart rate. For that reason, our favorite sports psychiatrist who took the survey really liked to use a tamoxifen as a non-stimulant alternative due to those concerns with the stimulant use of the more traditional ADHD medications. So next slide. So the use of stimulants in athletes, like I said, it is really the best choice, mainly because it works faster than most of the alternative medication choices. So the onset of action is quicker. You see an immediate effect. The long-acting formulations have less potential for abuse, so those should be really considered when utilizing the stimulant medications for ADHD. We also need to consider limiting use to just school and study and avoid use during practice and competition. We also need to use extra caution in athletes who are participating in endurance events in the heat due to the increased risk of heat illness with the use of stimulants. And like we know, it is prohibited by most or all sport governing bodies for in-competition use. So we need to be aware of that. And it requires therapeutic use exemption forms to be completed. So if you're at the collegiate level, those forms need to be on file before the start of a season. And if drug testing occurs, those forms need to be in place to show to the NCAA that this has indeed been documented. And it's not just sign on this dotted line. There's quite a bit of documentation that's required in order to allow the therapeutic use exemption to be approved. So making sure that we're helping with that and keeping those in order. Next slide. So the alternative medicines, like I mentioned, the tamoxifen is a norepinephrine reuptake inhibitor. It does not have performance enhancements that we see with the stimulant medication. It does take a little bit longer to take full effect, and so we need to keep that in mind. And sometimes it will be combined with stimulants to counteract some of the stimulant side effects. So that can be seen sometimes in use with patients. Side effects, similarly, you can have loss of appetite and nausea, but you can also have dizziness and fatigue. So again, paying attention to that when being used with our athletes. The other two medications are alpha-2 adrenergic receptor agonists, so clonidine and guanfacine. Neither of these have been studied in athletes, and they have some significant sedation and cardiac effects. And so again, we want to be careful in use in athletes, and these cannot be stopped abruptly. So they have to be weaned if we do have an athlete who is on one of these medications. Next slide. This is just, again, a graphic showing the different versions of the ADHD medications for your reference. So you can see kind of where those fall in line. And again, remembering the long-acting stimulants are the preferred if you have to go to stimulant use. Next slide. Okay, and then just briefly, a couple other areas to kind of sum up. In terms of medication for eating disorders, so there's really little evidence that any medication can be helpful in the management of anorexia nervosa. But there are some interventions or some research that does show that in treatment of bulimia, that antidepressants are actually quite effective. And fluoxetine is the one that has the most research and has been used the longest in terms of managing our athletes with eating disorders. Similarly, binge eating disorder, patients will respond well to lisdexamfetamine, but remembering that, again, this is a stimulant, so it is prohibited in competition and would require a TUE. And lastly, with our eating disorder patients, remembering to avoid bupropion due to the increased risk of seizure, whether that be for an anorexia patient or a bulimic patient. You really want to avoid bupropion. In terms of your management of the bulimia, fluoxetine, like I said, has the most research. That's not to say that you can't use the other SSRIs as well. Next slide. I wanted to just throw sport-related concussion on here just because there are a lot of there's a lot of pharmacology involved in various treatments of some of the sequelae of concussion. So there's really no approved pharmacologic intervention for concussion, but we often, and probably some of you have already, use some of these medications in the management of some of the symptoms that we see with our sport-related concussions. So for headaches, for instance, there will be use of nortriptyline in particular for protracted cases when headaches are really causing problems. I find it myself to be useful with the longer lasting symptoms. And again, just using cautions for the reasons we mentioned in the previous slides. Concentration issues, which is a huge symptom that we see within sport-related concussion. I always remember to encourage my patients who are already on ADHD medications to continue those medications. So for patients who have ADHD and then sustain a concussion, we want to make sure that we're educating them that now is not the time to stop their medication. And also in rare cases, we will sometimes add stimulants to people who don't have the diagnosis of ADHD, but have post-concussive symptoms that need help in the concentration realm. Insomnia in concussion, we really want to probably stick with melatonin. I would say that has at least potential for side effects in terms of causing confusion in terms of symptoms related to concussion and or side effects of a medication, whereas trazodone may give you more side effects. And then depression that can certainly coincide with concussion. SSRIs would be our first line choice, as it is with many of our other conditions that we've already talked about tonight. So next slide, the sports medicine physician's role. So what we need to do as sports medicine physicians is one, support our athletes and support both them finding the right team to help them with their mental health issues. And that includes us, but also psychologists and, preferably sports psychiatrists and sports psychologists if they're available in your community, but advocating for athletes. So when we don't have those resources, finding ways to get them the help they need in other ways, but also taking it on ourselves. I think a lot of us might be hesitant, aside from maybe depression and ADHD, sometimes getting into the weeds with these medications. It takes more time. It's a lot harder than doing a knee exam on a patient sometimes. And so really making sure that we're being advocates for our patients and stepping up and helping when we can. And then once they're on medications, whether we prescribe them or someone else did, watching for side effects that would be impacting our athlete, both in their everyday life and on the in the sport, as well as compliance on the athlete's part in terms of taking the medication. And then certainly the TUE oversight and implementation. So that can be a role that we can be very helpful with. Next slide. So in summary, in terms of the pharmacology of mental health, medications are often needed in our more severe cases, but also can be helpful in the less severe cases so that we can avoid progression of disease. And really, it's paramount for us to understand the potential risks and benefits of each of the medications that we're using. And ultimately, being an advocate for our athletes is essential in their success. So that is, I think, the end. If we go back, we can go back to the questions. You guys rock these questions. So just as a reminder, scenario number one, I think I said it about 5 times, bupropion, please don't give it in any type of eating disorder just because of an increased risk of seizure. Scenario number 2, if we go to that, melatonin is our best option for any type of insomnia or sleep-related disease. And then number 3, the medications that are banned by the WADA for in-competition use are stimulants, so that would be methylphenidate. So I know you guys did quite well on the questions at the front end of this, so congratulations. And then those are just the recommended resources. And I would say the top one, the sports psychiatry curriculum through the ISSP. They have a great curriculum. So if any fellowship directors are on here and don't know about this, I highly recommend you look at this because it gives great resources for all the different mental health conditions along with reading assignments. So it kind of helps round out a curriculum if you don't already have one. And then I have to point out that there's a new clinics in sports medicine coming out that someone we know is the editor of, and that's already online, but it's, I guess, printing in 2024. So it's a great resource with a lot of great authors in that edition, which would be a good resource to have for your library. And that is it. We survived. Thank you all.
Dr. Jaworski, that was awesome. Thank you so much. And what a difficult talk. You
Oh.
made it seem so simple. And yet, any of us who have been practicing in sports medicine know that there's so much nuance to mental health and managing this. I'm going to encourage everybody in the audience to please, if you have any questions, put it in the chat. But if not, I do have a couple of thoughts that I just jotted down.
Sure.
More because I want to hear your take on these. What are your thoughts regarding the influence of the NIL on mental health?
Oh my gosh.
I know.
It's making me have mental health issues. It's like every day you hear a new thing. So as a former team physician at Northwestern, I'm so glad I'm not a team physician anymore. So I feel bad for you, Siobhan. So I think, but more importantly for our athletes, I feel it has to have a huge impact on, the stress of being a college athlete alone is more than any of us can imagine for those of us who haven't been college athletes. And then to add on, like now you have to be like, basically like searching for a job all the time. Like you're constantly like looking for that next step, and the financial implications are so huge. And I think for some of these are really young and some, I hate to say it, but somewhat immature people who maybe don't have the best support networks to make those decisions. So I think that we, as their team physicians or as their sports medicine doctors in the community, need to be paying attention to that. And the pressures, I think sometimes they're being forced to make decisions that maybe aren't the best for them, but might be the best for maybe their family situation. And I can speak to having athletes at Northwestern. Northwestern's a highly academic school, and kids would wind up there and absolutely hate it. They would struggle, but they're like, I can't leave because I'm the first one in my family to, go to college. And if I don't finish this, there's just such pressure on them. And this was before the NIL and before all these other things. So I can't even imagine what it's like. So maybe you could tell us.
Yeah. I'll get back to you guys on that. Yeah. I agree. I also think it also, our job, and I think the medical community has done a really good job in destigmatizing mental health, having these conversations and just incorporating it into your conversation with anyone. It's just any normal question. How are you doing? It's like when we were in medical school and we were asking about bowel movements and, learning how to ask that question without turning bright red.
Right.
We have to do that with mental health as well. But it worries me that they're concerned about even revealing that for just fear of that getting out. So there is so much at play. And like social media, for example, the pressures of social media, and furthermore, the day and age that we're in with the decriminalization of cannabis, and this is turning tricky. And cannabis is being used to self-medicate for anxiety, along not just athletes, but general populations, medical students. It's becoming a problem. So it is a tricky thing. And
and I would say, like I was so fortunate. I came from Chicago, huge city, lots of providers, huge support networks for all that we do. And now I'm in a much smaller community, and learning to navigate, even as an experienced sports medicine provider, it's hard. And so I really feel for those of us who practice, and Park City, I'm not complaining. It's a great place, don't get me wrong. And we have great providers, but it's just limited. And so we have, 3 sports, counselors, and no psychiatrists, but they're completely to capacity. I think that where are we sending these people when we do identify the problem? And I think that's what I've seen is our high school and even our Olympic feeder teams here in town are kind of hesitant to ask the question, because they're like, if we ask the question and identify the problem, what do we do with it and how do we treat them? And so I think, again, it falls back on us as much as we can take on. And so it's a huge lift for a lot of people. And so I think many people have just tried to avoid it, which is not the right answer. So we need to find better solutions and having those resources. And I really emphasize that. I saw Margot's question, like the importance of emphasizing knowing who your providers are and who you can get, particularly if it's a mental health emergency, you know, that you need to be able to know who you can get this person to immediately. So
Yeah.
and we didn't talk much about that in this talk, but I think that's important as well.
So yeah. So, for those of you in the audience, I don't know if you can see the questions, but one of the questions from Dr. Patukian was, can you talk about how important it is to know who your mental health providers are and having a mental health emergency action plan? And for those of you out there, it is something that initially may not be a comfortable topic, but it is absolutely on us to be able to have those difficult conversations. And I mean, Margot, you can speak to this as well. Margot was part of the task force that came out with the SMAT, which is a really wonderful resource that the IOC put out, which is sports mental health assessment tool. And Margot, I please speak up if I missed something, but okay, phew. But you guys, it is a wonderful resource that you can print out. You can Google it, and it's called the SMHAT. So sounding like you're smart, but from Boston SMAT. It is, you can print it out, and it walks you through a really wonderful way. And thank you, Andy, for putting it right into the chat. Yeah. It addresses a number of different mental health conditions that you can triage for. So depression, anxiety, eating disorders, sleep disturbances, alcohol misuse, disordered eating, and it helps you figure out how to screen for these. So anxiety, the GAD-7 is on there. For depression, the PHQ-9, and these are tests that you can ask in a quick conversation and to help you figure out what do you think is going on. But there are resources, they require practicing. And so thank you, Andy, for putting that into the chat.
And I didn't include it because I was supposed to just do drugs, but it was so hard because there was so much more I wanted to teach about all the stuff we're talking about now. So I'm so glad you're bringing it up because we only had an hour.
Yeah, no, you're right. And also Margot had mentioned that the JAT, the Journal on Athletic Training, has a special session set to be published tomorrow, 2 editions on mental health. So, so there's more and more coming, you guys. Carrie, I was curious, this is something that I've come across. If you start an individual on an SSRI and they're not responding the way you'd want them to, and several weeks have gone by, you try a second agent. At what point do they fail an SSRI in your experience?
I would say, and I'm not going to say I have huge amounts of experience because I think there's probably people who have plenty more. But I think for me, if I've tried 2 SSRIs and it hasn't worked, then I'm considering other medications and definitely enlisting the help of someone else smarter than me in the psychiatry world to just help with those. Because I think my comfort level is probably the initiation of medications and, you know, a one switch or, you know, but when you're starting to combine these medications, I really would want, personally, I would want help to manage the side effect profiles because it does get a little bit more difficult, but I usually kind of use 2 as my rule.
Yeah.
And that brings up the point of, you know, do you taper off one and switch? And I think if you're switching between SSRIs, you can, there is the acceptance that you can just switch it.
Yeah.
But I think when you get beyond that, that's my comfort level.
Yeah. Yeah. And how do you manage the athlete that comes in and wants the pill and doesn't want the therapy?
Well, it's a lot harder in private practice than it is in a college setting where you have more control. So, I mean, I think I spend a lot of time educating, just like I do when I'm trying to convince the person with knee pain that they also need to do physical therapy and not just have an injection. So I think our society generally wants the quick fix and doesn't necessarily want the work that goes along with it. And so it just takes time and education. And so these are the visits that take longer, which is fine. I don't mind that. But I do my best to educate why you need the importance of the counseling as well.
Yeah. Yeah, exactly. I think it's the benefits of both is more than the additive nature of each. You know, they
Correct.
exponentially help each other. So you get so far with one, so far with the other, but together it's just really helpful.
And I think with this in particular, and the research does show that the psychotherapy, cognitive behavioral therapy, any of the behavioral treatments actually have been proven to be better, at least for depression. I can't argue as much for ADHD, but for depression, the literature that I see or saw, even when putting this talk together, really supports that medication, while we say first line, is really secondary to the therapy that has to go with it.
Absolutely. Absolutely. All right. Well, does anybody have any last minute questions? Carrie, Dr.
Oh, my
Jaworski, thank you so much for
oh yeah,
joining us
sorry for the
tonight.
glitches, but we got through it. So thank
We
you for
did.
having me.
It was
Yeah,
wonderful. Thank you so much. Thank you everybody for joining us.
yeah,
And
thank you guys.
if you guys get a chance, please feel free to shoot us some evaluations and feedback my way. And we appreciate you joining us this late Wednesday night. Thank you.